Uh, this Monday roundtable concept was, kind of the inception was like a month back or 2 months back, maybe. We thought we'll all sit down and maybe have a case discussion or case roundtable of sort with everyone, with different people from different institutions and maybe get their perspective. So this is the third edition of that program. This is being conducted every alternate week, so maybe twice a month, once every fortnight we're conducting it. The first two cases, if I remember correctly, the first one was a case of catatonia and a case of young onset case. What was the first case, Jigyasa? Do you remember for this year? No, it was for OCD. Sorry, it was the use of magical response to OCD. Some resistant treatment is in OCD. The second one was a case of young onset Parkinsonism who had developed catatonia. So the third one, we have brought a case of child and adolescent psychiatry. Okay, so I'll start out with the program. We have 20 people on board, so I think it's a good team to start off. So this is what it is. This is Monday Roundtable, a fortnightly case discussion in psychiatry. This is the third edition of the program. The case that we're discussing today is childhood OCD masquerading as an eating disorder, the complexities in the diagnostic interface. This would be a 45 minutes program. We're very time bound, so we will not make you wait longer than 7:45. Dr. Bhumika Misra is presenting the case. She is the resident in charge of the case in our ward. So she has prepared a presentation slide to demonstrate the case as well. I'll be moderating it. Dr. Jigyasa is actually the consultant in charge for the case. So I would also request her inputs during the discussion. And we're expecting Dr. Manohari ma'am, who is the professor of St. John's Medical College, Bangalore, and Dr. Satya Raj ma'am, who is also professor working at Department of Psychiatry, CMC fellow. So this is the agenda in the first 5 minutes, which is currently running. I'll give the introduction, then I'll ask Dr. Bhumika to present the case for the next 15 minutes. We'll take inputs from the GET discussant for the next 10 to 15 minutes, and we'll take up queries. I request all those who are participating, please post your queries in the Zoom chat box so that we can take it up for discussion. Okay, that's it from my side. I believe we should start. Dr. Bhumika, I'd request you to share your slides and you can go ahead with the presentation.
Dr. Udit, before that, can I just give a brief introduction about our two discussions?
These discussants have joined in, no? Good. So please go ahead.
Okay, so we have today with us Dr. Manohari and Dr. Satya Raj. I welcome both of you to our program, and it's an extreme privilege to have both of you on the same platform. Actually, Dr. Manohari happens to be my teacher, and she is my guide, under whom I have been trained in child psychiatry. And I have learned whatever I have learned in eating disorder is from her, and she has been very instrumental in actually shaping the way clinical care is being given to this category of people. And ma'am is extremely, obviously, her clinical acumen and the way she approaches the case. We see her as a mother figure. So that is how we have been there with you. Thank you so much, ma'am, for joining us. We really look forward to your inputs. Thank you, ma'am.
Thank you for the kind words, Jigyasa, and I'm very happy to join you here.
Thank you so much, ma'am. Dr. Satya Raj, actually, I have not had the chance to work with you, ma'am, but I have heard a lot from Dr. Jaiprakash Rastan Ravan, sir, about you, about the kind of work you do, about your passion, your dedication, and we thought it would be really worthwhile to have your inputs as well. While we have Dr. Manohari, and we thought your inputs will also play a very important role in shaping the way we take this case ahead. So thank you, ma'am, for joining. And Dr. Ravan will be joining soon also. Once he joins, he'll say a few words about his experience of working with you. So we are looking forward
Thanks a lot. Thanks a lot, Dr. Jigyasa. Thank you so much.
Thank you.
Happy to be a part of this whole endeavor. Thanks.
Thank you, ma'am. So now I think it's over to Dr. Udit. Maybe he can take the case.
Thank you, Manohari ma'am. Thank you, Satya ma'am, for joining. Dr. Bhumika, you can actually start your presentation. You can, I have made you a co-host. You can say your slides and start the case.
I hope my slides are visible.
Yes, ma'am.
All right.
Could you do it in a full screen mode, ma'am?
Yeah. So today's good evening, everyone. Thank you all for joining us today. The discussion today is based on childhood OCD masquerading as an eating disorder and what are the complexities in the diagnostic interface. So starting the discussion with the demographic details. This is an 18-year-old boy, completed his class 12 and would be joining MBBS course, staying in an extended nuclear family, belonging from a higher socioeconomic status, and the main informant is the mother. The child came with chief complaints of refusal to take food, self-induced purging after food intake, and repetitive recurrent thoughts that he should stop taking food and drink because he's depleting world resources, the urge to harm himself, and a weight loss of around 13 kgs in the last 2 to 3 months. So the onset of the illness was insidious, the duration was 2 years, and the course is continuous and progressive. So coming to the history of present illness, around 2 to 3 years back, it was during the COVID lockdown that the child reported of having difficulties due to the change in the schedule. And he reported being unable to cope with the situation. As we all know, there was a shutdown of schools and he would stay at home. So the symptoms started at this time. At that time, patient's weight was 72 kgs and his BMI was 24. Child reported of feeling that he had gained too much weight and there was significant body image issues related to that. Also, he had a poor self-esteem, which was subsequent to the bullying that he had faced. I would be elaborating more on that in the later parts. Child mentioned that initially he stopped eating food items that he enjoyed, for example, junk food and non-vegetarian food, as he said that he would feel worse about his self-image after eating and it would amplify his guilt. Later, he mentioned that the quantity of food intake started to significantly decrease and child even started to spit out water that he would take. There came a point that after every food intake, he would purge out food by gagging, by putting fingers inside his mouth. Gradually, this child started believing that nothing should enter his body and he would even spit out his own saliva. The child also mentioned that during this time, he started having recurrent, repetitive, distressing thoughts that he is harming the world by utilizing all the natural resources such as food and water. The child would think that even by breathing air or he is depleting the oxygen around, and by doing so, he considered himself to be a criminal as he was harming animals and plants and taking up all the resources for himself. After every food intake, this feeling would exacerbate and child would start feeling anxious and distressed. This relief of anxiety was only temporary after every purge and it lasted until the next food intake. There was a lot of guilt which was also present secondary to the food intake, as the underlying theme was that the child was being selfish by taking up all the food and resources for the rest of the world. So in the last 1 year, the parents and the attenders started noticing a change in the behavior in the form of irritability and anger outbursts on trivial issues, altercations with the family secondary to the food refusal. So whenever he was given food, child would spit out food in front of the parents or would not take it inside, because of which there were a lot of interpersonal issues between the family members. The child mentioned that he would know that at some point these thoughts are irrational, but he was unable to suppress them at all. There was also, he mentioned that an intense urge to harm self by slitting his throat or from jumping from buildings. However, there was no act of any self-harm which is committed. Overall, there was a loss of around total 13 kgs of body weight and the current BMI dropped down to 17.9 from 24. The child also mentioned that there was a fear of becoming morbidly obese and that he would feel uncomfortable about any weight gain. So what we couldn't find in this case was there was no history of any binge eating episodes, any use of laxatives, eating non-nutritive food items or any regurgitation of food. There was no history of any repetitive thoughts of contamination, followed by compulsive acts of hand washing, any sexual or blasphemous thoughts. There was no history of any persistent or pervasive low mood or any anhedonia, loss of energy, or any significant sleep disturbances. No history of any suspiciousness, muttering or smiling to self, hearing things which are not heard by others, and there was no comorbid any other medical condition which is present. Coming to the family history, child is an only child staying in an extended nuclear family with the the paternal grandparents and the parents. So the father is 46 years of age and is a software engineer by occupation. The mother is a homemaker and is 43 years of age. Coming to the family history, so we have a history of psychiatric illness, which is suggestive of psychotic in the paternal grandmother, for which she was on medications for a very long time. There is also history of suicide in the first cousin in the paternal side, 10 years back by hanging. And there is also history of paranoid schizophrenia in the paternal cousin, for which he's taking medication still. On the maternal side, there is history of seizure disorder in the maternal grandmother. There is history of obsessive compulsive disorder in the child's uncle, who is on treatment for the same. And there is history of severe autism in the uncle's child, so the child's maternal cousin. Also, overall, regarding the parenting, the mother's parenting is restrictive, and there is history of inconsistent disciplining pattern among the other family members. So the father is usually isolated and not very involved in the child's upbringing, and the sole caretaker or the sole family member involved in the child's daily activities is the mother. The family environment overall is warm, but there is too much attachment with the mother because of all these reasons. And the overall impression is that there needs certain interventions required in the family dynamics. The family notion about the child's problems, they had a good knowledge and acceptance because most of the family members had a medical background. So his maternal grandfather and paternal uncle, they are all doctors. So they had a good knowledge and acceptance. Coming to the personal history of the child, prenatal, there is history of maternal infection in the second trimester, the details of which are not really available, but they mentioned that it was a bacterial infection and which had detected in the ultrasound scan, which showed the growth restriction of the child. And the mother took an antibiotics course for 15 days. Also perinatal, it was a full-term normal delivery. The birth weight of the child was around 3.4 kgs and he cried immediately after birth. Postnatal, there was history of jaundice for which phototherapy was given for 3 days. The child was breastfed for 2 months, after which the mother mentioned that she would have difficulties to feed, after which he was given only formula feed, but no history suggestive of any low weight or lack of failure to thrive. Also, developmental milestones. Mother gives history of delayed speech milestones, but she does not really clarify as to how delayed, and not giving much details about the milestones. But there is history of delayed speech milestones. So coming to the schooling history, the child started school at age 4. At this time, the parents and the child, they were staying in UK. So they were in London. And at that time, child was promoted to a higher class because of exceptional performance. And he is academically very good. 10th, the child has scored 96.5. And in 12th, he has scored 93%. However, when the child was around 5 to 6 years of age, when they were in UK, the school teachers had mentioned to the mother that the child was not talking or behaving like others of his age. For example, everybody used to call the class teacher by her last name, and the child used to mention only her first name or something of that sort. So the child was not talking or behaving like others of his age, and he insisted on sameness, preferred lone play. At that time, they mentioned that the child was diagnosed with mild as autism spectrum disorder or Asperger's, and there is also history of being bullied by peers till sixth standard. The child mentions that there was no physical like beating up by his peers, but they would call him by rash names, and he would find a lot of difficulty making friends. So there were also episodes of school refusal due to this reason. Coming to the temperamental traits, so the activity level of the child is normal. The rhythmicity is regular. He had a low distractibility. However, the approach or withdrawal was positive. He was, however, not adaptable to situations. He took a lot of time. The attention span and persistence was also high. The intensity of reaction to a situation was mild. The threshold of responsiveness was also low, and the quality of mood was more towards the negative side. Coming to the physical examination of the child, so height is 169 centimeter, weight around 51 kgs, and he had a BMI of 70.9. The head circumference was normal, no macrocephaly could be found. There were presence of certain dysmorphic features like large ears and a broad mouth. There is also presence of a high arched palate. No features of pallor icterus clubbing or lymphadenopathy were there. On examination of the skin, we could not find any cafe au lait spots or any neurofibromas. He also had long fingers, that is arachnodactyly, but no simian crease could be seen. And apart from that, systemic findings were all normal. Coming to the mental status examination, so on general appearance and behavior, the child appears thinly built and nourished, does not maintain eye contact, and has a downcast gaze. The social engagement is such that there is poor initiation and reciprocity from the child's side. He is able to answer questions, but it is very difficult to engage him in long conversations. The receptive and expressive language ability is also poor. Subjectively, the mood is well, and objectively, he appears anxious. The activity is present, but there is poor self-regulation of affect. Coming to the thought process, so the predominant thought, the theme of the thought was obsession regarding the food intake. There were ideas of guilt, body image issues, and I'm not sure about this, but seemed like suicidal ideas. The child's version of problem, if you ask the child what is a problem, he would say that I'm feeling anxious due to my thoughts. The suicidal thoughts and ideas were present, but they were not intense. He had a good intellectual ability. And on the 3-wish test, when asked the child about 3 wishes, the first wish, he said that he wants to become a neurosurgeon so that he can heal people. The second wish, that only good things should happen to everyone. There should not be any bad things in the world. And the third wish, he said that he wanted to stay in the hostel when he starts his MBBS course, as he wants to become independent and he doesn't want to be around his parents. There were no perceptual abnormalities which were detected. So coming to the diagnosis, so the first, according to the Ratter's multi-axial diagnosis, this is the eating disorder, anorexia nervosa. I would not really say fitting into any of the subtypes, but it has features of both restrictive and purging type. And along with that, obsessive compulsive disorder. Then is the autism spectrum disorder with normal intelligence, no medical comorbidities, and family psychosocial interventions required, especially on the parenting and the style of family dynamics, because it is only a lone parent who is taking care of the child, the father being away from the family and not really very involved with the upbringing of the child. The mother has expressed too much of attachment with the child, and this in some ways is affecting the child's, is acting like a perpetuating factor for the child's illness. Before coming to the management, I wanted to show you all a video. So this has been taken, this video is taken by consent of the mother. Is my screen visible?
Yes, ma'am. Your screen is visible, but your video is not visible.
Sorry,
Your video is not visible, ma'am.
video is not visible.
It's the PPT that is showing it. The video is not coming. Maybe you can stop sharing the PPT and bring the videos. And instead of sharing your screen, no, you can go to the advanced sharing and there is an option to share the video. That you can do.
Yes, sir.
And Bhumika, you'll need to wrap up in 2 minutes. We'll have to go to the discussion as well.
When we started late, no, Jigyasa, let it take another 5 minutes. All right. The case is very interesting.
I hope everyone can see.
Yeah, it's visible now. Go ahead.
Yeah. This is a video taken by the child's mother of him eating, and this is the way he spits out food. So as you can see, there was no ingestion of food. Whatever the child is taking, is just chewing and then spitting it out. The mother has also caught him on various occasions trying to gag and vomit out food. So this is the basic pattern. Coming to the management aspect of it, initially, which sorry. Yeah, so initially the challenges that we faced was that the child would refuse to take any food taken in and would automatically vomit out. He also had difficulties in swallowing. However, the investigations that we did showed no specific abnormalities. On assessment in the child Yale Brown obsessive compulsive scoring, on the checklist, the child scored in the past, there were features of aggressiveness, there's thoughts of aggressiveness, that is fear of harm to self and others. And he also scored on repetitiveness and symmetry. And the score overall came around 24, that was moderate to severe. In the social reciprocity scale, he scored around 63T, which is mild difficulty in social interactions. Currently, the patient is being treated with around 80 milligram of fluoxetine in 2 divided doses. And the patient and the parents report around 20 to 30% improvement in symptoms. And this is further augmented with aripiprazole around 10 milligram. So psychotherapy, non-pharmacological management, we went with CBT, that is cognitive restructuring, and also asked him to maintain a thought diary. So what we did in cognitive restructuring was that we spoke to him about the caloric values, about the different food items, and about the significance of him spitting out, and about that not contributing to him having the underlying notion to help save the world or help others. So we try to restructure these erroneous ideas and facing the irrational fears about food and weight in conjunction with techniques which emphasize increasing readiness for change and motivation, mindful eating by speaking to him about the calories, and learning more effective stress management skills. A brief discussion on this topic. So as we all know,
let us stop here and we'll probably discuss with our discussants.
all right.
You can stop sharing. Thank you, Dr. Bhumika, for a very comprehensive worked up case as well as the presentation. Dr. Jigyasa is the consultant in charge of the case, and there are a few people who have joined us midway through the presentation. So I would request Dr. Jigyasa to give us a very brief summary of the case and maybe take the discussion forward.
Yeah. So thank you, Bhumika, for the presentation. So this case we have here is a 18-year-old boy who presented to us with a 3 years duration of illness and a very severe worsening over the last 3 months. And the primary symptoms at presentation included refusal to eat. And whatever he would eat, he would spit it out or maybe actually induce vomiting and get it out of his body. And that resulted in a significant weight loss, about 15 kgs in the last 3 months. In addition to that, upon asking about why is he doing that, most of the time the reason he would say is, I feel guilty of consuming the resources of the world. There are a lot of people who do not have resources, and I eating it is actually making me feel guilty. That is why I need to throw it out. So that was the second chief complaint. The third thing was he had some irritable and anger outbursts, and the family was actually trying to force feed. So the behavior problems were also quite significant when he presented to us. So with this, when we tried to initially assess, at the outset, it looked like more of an only eating disorder. Unless and until, because the child verbalized the reason for it after some time, after we established some rapport, and it took us time to find out there was a OC kind of a thing that was behind it. So currently, he was admitted, he was being treated outside also, and with us also, he was there for quite some time. And now he has joined a medical course. He wanted to be an undergraduate student, and his academic functioning was also good. To our surprise, when we interacted with the child, the autistic features also came into foreplay, because the way he was maintaining eye contact and the way he was conducting himself, we had a suspicion possibly he could be on the spectrum. And actually, the mother confirmed it, and that was only like maybe a few days back that we got that history. They were not talking about it at all. They were completely denying it. They were saying all milestones were normal. There was no problem, no problem. Only problem is last 3 months. So, but going back now, when we came out with the spectrum kind of a thing, so everything started falling in place, and we started realizing, maybe as we all know, autism and then eating disorder and OCD, the complex interplay, it can happen. And we thought this case is quite interesting to bring to a discussion forum and have inputs from our esteemed child psychiatrists of the country. So why we brought this case to discussion is particularly to highlight the difficulties in the initial phase when getting a diagnosis, where eating disorder can be comorbid with OCD, but we were not able to get through because the child had difficulty in communicating what was the exact reason. And only after maybe at least a long time, he started verbalizing this clear OC. And in addition to that OC, he also had this thing, if I take air also, I'll be depleting the world's oxygen. And that is also making me feel guilty. And to reduce his guilt, he would do activities. One is vomiting, one is spitting. The other things he used to do is he used to actually hide his face under the blanket at times, because I don't want to consume oxygen. So those kind of things also hit it. However, we were unusual. It was difficult for us to find out any patterns or any other ritualistic behaviors right now, or any elaborate routines around any activities. But and the BMI also, it is dropping only now, not in the initial part. So eating disorder definitely, but we were not sure if it is fulfilling the criteria for anorexia. So ma'am and maybe Manohari ma'am can throw some light on it. Ma'am, what do you think? Should we treat him in lines of eating disorder only, or should we treat the OCD first and then go to the eating disorder proper? Because right now, maybe what we are doing is only treating the OCD, eating disorder part. We are not able to address it adequately, although we have started taking some food intake. Ma'am, how would you want us to take it?
I think I'd like to start by congratulating Bhumika and Jigyansa for the wonderful presentation and throwing light on all the complexities of the case itself. And like Jigyansa mentioned, it is well known that there is a strong combination of interlinked disorders of anorexia and anorexia nervosa, as well as OCD and autism spectrum disorders, especially Asperger's disorders. In this child, my thought is that the boy could be depressed also. The thoughts, the things that make me think is that lack of any pleasure in any activities that he used to enjoy, you mentioned, and guilt, suicidal thoughts, as well as that quality of nihilism to what he's describing. I will consume all the air and I will deplete the world, and So that element of nihilism is there in those descriptions. And we do know that in young people, depression can be prolonged, and that pervasiveness of low mood is often not described by a young person. It is mainly by observation and all the other additional features that we come to the conclusion that the child could be depressed. And especially for a child who has Asperger's or is in the autism spectrum, that ability to recognize and emote or describe feelings of depression might be impaired. But all the other features, that worthlessness, that hopelessness, and especially that nihilism, makes me wonder that depression also could be in the forefront, and all the other difficulties might be part of the depression itself. And from our own experience, we do know that lots of young people who come in for management of eating disorders do have a comorbidity of mood disorder, especially depression. And getting the depression sorted out seems to help in going forward with the eating problems itself, as well as the OC symptoms. I think pharmacological management seems to be fine. My personal preference is not so much for fluoxetine. Mainly, I don't know, all Western studies say that fluoxetine works and it is the best. But my personal experience is that fluoxetine, we don't have that much success rate with fluoxetine. I don't know whether it is the quality of what we get here, or I'm not sure, but I'm not very fond of fluoxetine. I tend to use escitalopram more than fluoxetine, but he's on 80 milligrams and we need to give it an adequate period of time before deciding it is working or not working. Target symptoms for the antidepressants, in my opinion, would be for the mood symptoms, for that nihilism, and the OC symptoms also, as well as the preoccupation with body image, as well as eating. The non-pharmacological interventions, I know you said you are stuck with how to proceed, and it is very, very difficult. I think we have to work simultaneously with the eating problems as well as with the OC symptoms. And I don't know in this child whether cognitive aspects of the CBT can be used as much. Probably sticking to the BT aspects of it, more focus on the behavioral aspects. Say, for example, the spitting while he's eating, whether we can use any behavior method to prevent that from happening rather than too many cognitive aspects of treatment itself. I'm not too sure he can participate so much in the cognitive aspects, or it might be more mechanically recording rather than actually being able to describe his feeling or thought so much. So my suggestion, my thought would be that we focus more on behavior methods, especially for the spitting and the eating problems. Educate him, definitely educate him about the calorie requirements and all the OC, all the things that we would do for an eating disorder, which is basically educating him about food, need for food, normal body weight, calorie value of food, and how much energy is required to maintain the BMR. And so focusing on those aspects, give him information, give him written information or good websites that he can use to become aware of what he should eat and why food is essential, especially if he's planning on being a neurosurgeon and things. The other thing that the OC symptoms, I think you are handling it. Maybe it may not be possible to work so much with the OC symptoms. You might need to wait for the fluoxetine to work before proceeding further, but definitely the response prevention aspect might be more than the CBT aspect itself is what I'm thinking. Then I really would look at the prognosis and suitability of doing medicine and neurosurgery for this child. the passion he has for it might be there, but the amount of stress he has to undergo and the strong family history, his own vulnerabilities, whether he's on the right path or whether we need to counsel him about those. Very, very delicate issue, but many times we just don't address it. We let it go on, and then later on we might be wondering, did we do the right thing in letting him go through so much of effort and stress, and is it worth it? So that's also one thing we might need to discuss, if not with the child, with the parents at this point, before looking at other things.
Sure. Thank you so much, ma'am, for highlighting all the intricate issues, starting from diagnosis, the complexities in the interplay and the patroplasticity also, and the management challenges. Thank you, ma'am. I was also curious, Dr. Satya, ma'am, if you could throw some light about what is your experience in dealing with such cases. Obviously, you must be dealing with a lot of complexities as well. And this autism and eating disorder and it is a known comorbidity, this entire thing. Ma'am, what is your experience in dealing with such cases, and what are the issues you want us to also manage?
Thanks a lot. I would first sort of say, Bhumika, it was a very nice presentation, and I think you've taken through it well. A few points I'd like to add. So, ma'am had mentioned a lot about the practical aspects of pharmacological, non-pharmacological management and the challenges. I see a lot of PGs logged in as well. So I'm just thinking, for a person who is doing psychiatry, what are the things we sort of need to understand, right? A symptom versus a syndrome, right? So the first thing to start with, that is the basics. So if you're going to take that, I would perfectly sort of agree with Dr. Manohari, because that's the first thing I made note of. Because in adolescence, you see irritable mood being more common rather than a low mood and anhedonia, and significant guilt. And the rates of comorbidity with anorexia and are significantly higher as well. And if you take the diagnostic hierarchy, what are we taught? We go through organicity, substance, then come to psychosis, then come to our mood disorders, then come into the anxiety spectrum, right? And then the eating, and it goes on. So hierarchically as well, and if you're going to look at the prevalence rates of comorbidity, I would definitely go by a comorbid diagnosis of a depressive episode. Definitely taking into consideration that the depression is very prolonged in children. That's one thing. The second thing I'd like to sort of mention is look at the form-content dichotomy. What do I mean by that? Going to basic phenomenology back to our early sort of teaching. What do we teach? So form is how it is expressed, and content is the exact complaint which they are telling us. Here, the form has an obsessive nature to it, right? Whereas the content is that of an eating disorder, right? So that is where the complexity lies. And look at the spectrum concept. Where will you put this boy? There are three ways in which you can look at it. Definitely, if you take a multi-axial diagnostic perspective, I think that was done, looking into a high-functioning ASD, Asperger's, or whatever in the different diagnostic category, if you were to take him like that, with a depressive episode, right, and sort of OCD with anorexic symptoms, OCD with comorbid anorexia, or anorexia with a lot of ritualistic behaviors, right? Because we are not getting any other obsessive symptom other than the ritualistic way of him doing things, right? So he's somewhere on this spectrum, right? And you would see, as the phenomenology evolves, how children vacillate between both ends, right? That's a very, very common presentation. So two things I'd like to sort of take sort of like PGs to look into is the form versus content dichotomy, where they can make up their minds and give a more clarity to the phenomenology. And the second thing is the symptom versus syndromal and the spectrum concept. take it for, if you were to talk first about, I'm not taking depression, I'm not taking ASD. If you were just to take anorexia and OCD, you have enough and more meta-analysis, right? Which have shown the overlap of symptoms. I mentioned a few showing the, see, take it phenomenology wise, take it defense mechanism wise, take it neurobiologically, like a 5-HT dysregulation, right? They have a common base, right? And what evolves later on is different, right? I might have a little more of anorexia, someone else might have a little more of OC. So that's how I view it, right? 2, 3 more things which I wanted to clarify and add are definitely when you're presenting an Axis 6 or a global assessment of functioning must be mentioned, right? Because you're telling me this is a boy who's written his 12th, got a good grades, and then joined medical college, but then absolutely spitting and not taking his food with the BMI dropping now. So what is the level of functioning? Because why have they come now? We know that OCD is very sort of hidden, eating disorder as well. So very later on into the illness onset is when we get to see them. But what made them come now is one question I would ask. And 2, 3 more things, Bhumika, when you're looking at a case of OCD or eating disorder, when you're looking into a family presentation, if you look into like a systems approach, I would say like certain terminologies, mother is more attached to the child rather than saying that. I would say it's an enriched relationship, right? Coming back to our basics of Philip Barker and family therapy, I would mention it as an enriched relationship. And why is there an absent father? What would give you a clarity in diagnosis is going on a little early. And this is, how should I say, comorbidity, as we say, is how should I say, rule rather than an exception. Finding out things only in week 2 or week 3 is also very well known with most of our child psychiatric conditions. Oh my God, you didn't tell me this so far. That's the response we get. And we realize how much we have missed. So I don't think we are going to be alarmed about that, right? So pharmacologically, one more thing is just do an eating disorder inventory. Get a medical sort of evaluation done, because now that he's losing weight rapidly and you're trying to feed him in the ward, he must not be going into a refeeding, right? So that's one thing I would try to ensure medically. That's one thing about the anorexia. Then coming back, ASD in the background is going to be very, very challenging, both for your even establishing a rapport, as ma'am said, getting a cognitive form of behavior therapy done in the true sense. How cooperative is he going to be? And again, if you go back and actually clarify, a child with ASD will have a lot of ritualistic OC traits. Tell me one thing, anybody in the thing, what will make you differentiate between an OCD and an eating disorder predominantly? OCD is ego dystonic. The eating disorder is ego syntonic. The difficulty here we are having is this child is vacillating between both. On one hand, is saying, I'm going to sort of get rid of all the world's resources, or I'm not going to sort of breathe. And then you're wondering, and then he says its own thought, he's distressed about the thought. On the other hand, he's also had early childhood bullying. Someone has told him he feels he's gaining weight. So you brought about the body dysmorphic and the body image distortion as well. Right. So this is where I would get worried. Right. I'm sorry, I'm blacked out because I don't have power in my office. I'm very sorry. Hopefully you see a ghost in some voice. Fine. So this is the major thing I would like to highlight, right? It is a diagnostic challenge when you're sort of trying to take it, but I think you're on the right track and well managed. Include the family as well, right? Like most of us know, eating disorder across the globe is now using a model is family-based intervention. So trying to be, rather than him sitting and eating alone, if the family can be a part of the meal and trying to incorporate these things, because I perfectly understand the challenge in managing an OCD at one hand and trying to manage an AD at the other end. Absolutely difficult to top it all with a neurodevelopmental disorder in the background. Perfectly understandable, but just get the basic medical things done. Get an eating disorder inventory done, I would say. And definitely, as ma'am said, You can do Bex, or you can do anything. I'm very more than sure that he would definitely have a syndromal depression as well, right? The other thing, pharmacologically, I think fluoxetine is good. We can give a good trial, as ma'am said, but I think in case, I don't know how long he's been on it, but in case it's 6 to 8 weeks and you're not seeing a great change, I would give a trial of either fluoxetine or sertraline or escitalopram, as ma'am said, go according to the category as such, right? And the other thing is, one more thing which I wanted to add is fluoxetine, maybe not as a BD dose. We know about the half-life and other things. I would rather give it a daily dose to see that he doesn't have gastritis as well. So any particular reason for choosing aripiprazole? I was getting a little boggled as to why aripiprazole. Any specific reason? He would do well with some weight gain and increased appetite, right? I would rather, I don't know, I would rather use a low dose of olanzapine as well, 2.5 of olanzapine or 1 milligram of risperidone clinically, to see in most of our ED patients, we use that so that they're not very happy. I'll tell you that once they start gaining weight, they're going to sort of be a little worried. But then the initial rigidity and that resistance, more so because they have an ASD background, will be slightly more beneficial rather than aripiprazole. These are my personal thoughts. As I said, there's nothing against aripiprazole, but these are just my personal experience, which I'd like to share. Anyway, well presented and a very interesting case, and keep us posted about the prognosis as well as to how he's doing. Thank you so much.
Sure. Thank you, ma'am, for that input. Actually, I'll also mention Dr. Raman happens to be the unit head. So he has also joined, and this is the exact suggestion, the last one that he made, to actually start olanzapine or risperidone instead of giving aripiprazole. But by the time the child had come to us, he was already on a low dose of aripiprazole. So we thought of maybe increasing it a bit further before switching it to another medication. That is what we thought. So that is the only reason we'd have
I
more.
mean, that's a fair call. that's fine. It's perfectly fine, and I think it's managed very well. So all the best, and it's challenging times, but you'll go through it. It's just about the threshold of breaking even somewhere. So just need to establish a rapport. I would say in case he's cognitively really smart and sharp, though not maintaining a cognitive diary or other things, these kids do very well with a lot of, how should I say, doing computer assisted things. See whether he would like to sort of do that or draw or something, to use more of BT, but with a modified tinge of the cognitive component, so that it would be more acceptable for him. Thank you.
Dr. Manohari, ma'am, please go ahead with your question.
Yeah, I just wanted to say a word about use of aripiprazole versus olanzapine and risperidone. I agree that the initial benefit of overcoming the rigidity, it is much quicker with aripiprazole or olanzapine. But when a child is consistently working towards losing weight and be giving medication that will make them gain weight, they're going to reduce their intake even further, because inadvertently what the mechanisms by which weight gain happens may not always be related to the quantity. It is not always just the increase in appetite which is causing the weight gain. So it may be very difficult to continue olanzapine or risperidone if they start gaining weight because of that, rather than because of making a conscious decision to eat a proper meal, to have a balanced diet, and hence move towards having an appropriate weight. So in our center, we tend to use aripiprazole more than any other antipsychotic, mainly because of this reason. So aripiprazole does take a little longer to be helpful. There are times in the short term that we have used risperidone. We hardly ever use olanzapine because of the much more rapid weight gain. But most of the times we tend to shift to aripiprazole in say 3 weeks or 4 weeks time, because we don't want that additional weight gain that medication can cause. And all the SSRIs, sometimes even fluoxetine, can cause weight gain again, which is very distressing for the child. When they are consuming just 1,200 calories, are struggling to maintain a BMI, which is much lower than what we would recommend. This additional weight gain becomes more of a problem, and their restricting intake becomes even more prominent. So I thought aripiprazole would be
sure. I think
good
it's
choice
an
that way.
individual choice, because
Yes,
my thing was like, if 10 milligrams of aripiprazole is not augmenting and doing what it's supposed to do, you might as well see the clinical benefit and then in the continuation phase switch over when you see some gains. Because the more chronic this child is going to be having the symptoms, it's going to be even more difficult to break the routine. So
Yeah.
I think it's a personal choice, ma'am, because we too tend to use it, because we use it only when children are in IP. And as you perfectly said, 3 weeks down the line, the rigidity is broken, the child is a little more cooperative, my rapport is better established, and then I switch over. So then it becomes like a point of, see, you do this for me, I do this for you. And then it's like a very nice rapport, and then it works. So perfectly acceptable, ma'am. But if 10 is not helping, then I would be a little worried, because that's a very good dose for augmentation. And still, if that's not doing the job it ought to do, I would reconsider.
Sure. Yes, I agree.
Thank you all the discussions for a very engaging discussion. One thing I noticed, for the first 2 editions of this forum, we used to get like 20-25 cases in the chat box. Today there is absolutely not a single question that is there in the chat box. People are listening, all with their attention. There is a question posted right now. So Dr. Anirban is asking if there is a failed trial of fluoxetine, can we start clomipramine as a second choice, not a second SSRI?
Can I, ma'am, do you want to answer that, or shall I go ahead?
Please, ma'am, please go ahead.
I think, see, we are using an SSRI for multiple purposes here. We want the depression to be better. We want the OCD to be better. We are also wanting to decrease the thoughts about the preoccupation with body image and eating itself. It is difficult. There is some evidence that tricyclics really don't work very well in adolescents for management of depression itself. And with the low body weight, with the difficulties in electrolyte imbalance and things that refeeding can cause, tricyclic may not be a good choice for any child with eating disorder. And as well, the same side effect of weight gain and things. So I would prefer to avoid a tricyclic, including clomipramine, and prefer a second SSRI.
Same thing here, ma'am. I perfectly would agree with that as well. I think, ma'am, it's perfect. I think definitely a second SSRI would be the option, and a more how should I say, stronger focus on the non-pharmacological management and the family involvement as well. I think that is very, very essential. Taking a family therapy perspective and sort of dealing with it is also very important. Ma'am had mentioned about certain things like psychoeducating. See, this becomes the difficulty when there is a dual or a triple diagnosis, I would say. It is like very difficult. And you're talking about here at least 3 diagnoses in Axis 1 and 1 neurodevelopmental diagnosis. So it's not an easy job. But then I would say, rather than getting and running behind one symptom after the other, for the first admission, have time limited admissions, say 4 weeks to 6 weeks. This is my target symptom. I'm going to do this. I'm going to start working on. So then the child gets a break and the child gets a vision of what is actually going to happen. Once they're able to do that, then their acceptance of therapy and commitment to it might be a little better. Rather than, oh my God, I'll sort the OC, then I'll sort the depression, then I'll sort the ED. We will be sorting out many things, but you won't see the child being, or adolescent being, very cooperative with us. So maybe giving the child a time frame also helps a lot. And then I can see Dr. Kajal having asked about sensory issues. I think that's a very important thing to look into. We know that ASD children do have a lot of sensory issues, specifically oral sensitivity, the texture of food, the taste and other things. Whether there were any food fads or any specific food preferences or feeding disorder related issues during early childhood, I think that's something which definitely needs to be clarified. I'm sure ma'am can add on. And possibility of abuse. Okay. So I'm not sure why that was thought of, but anyway, introducing theory of mind concept, definitely yes. Yes, definitely that would help. But I said that would be a little later in the therapeutic sort of once I've established a rapport going to the theory of mind. I would rather manage the psychopathology actively first. Ma'am, please add on, ma'am, because whatever you want to add.
Those are important issues for a little later, I think. I think
Yes, ma'am.
initially we need to focus on the depression and use simple behavior techniques to help with the eating difficulties
Sure.
and with the OC symptoms. Subsequently, we can look at all the other aspects.
Sure.
It is likely that being in the spectrum, he must have had sensory issues, especially oral. But I don't think that is going to impact management now,
Currently. Sure, ma'am.
current difficulties. Abuse, yes, there seems to be bullying. Whether there was any other kind of abuse, I don't know. In the thing itself, I remember that he was promoted to the next class and things. So whether there was a lot of pressure on him to study, or he was having the hyperamnesia, so that he was able to retain and reproduce, and hence able to get more marks and move on, rather than well-rounded adaptive behavior functioning, is my thought. So I'm not too sure why the abuse question, why it needs to be ruled out. In all children who have multiple difficulties and who have neurodevelopmental disorders, that's something to explore, but I wouldn't say on priority here. I didn't get any reason for worrying about it. Theory of mind definitely, as ma'am said, it will be helpful. I think a little later. I think now focus
Sure,
on
ma'am.
depression, use simple methods, get moving forward, build rapport,
And
and
then do it.
before we can move.
I'll probably abuse my privilege of being the moderator and ask a question that is bothering me. So we have a family history of schizophrenia in this case, no? Is it possible that we are dealing with maybe early phase of psychosis or maybe prodrome? Is it a valid consideration that we can have?
Shall I go ahead, ma'am?
Ma'am? Yeah, ma'am. Sure, ma'am.
Yeah.
Please. I'll-
The prodrome tends to be more of negative symptoms, loss of interest, isolation, and more quieter and things. This is a child who's managed to get 93%, who's managed to do his NEET exam, get his the admission to a medical college, and focus. His preoccupation seems to be with eating and body image and the nihilistic thoughts, and so
nihilistic or kind of pseudo altruistic, if in the lack of
altruistic, yes, but along with the guilt and worthlessness, and that he is destroying, whether we can look at it both ways. But if you look at it as if there was no worthlessness or hopelessness, then I would consider it as pseudo-philosophical and be more concerned about the prodrome. It is quite well known that young people can start with a mood episode or with a psychotic episode, and then later on go to have a different kind of illness. Start with the mood episode, more depression as well as mania, and the second or third episode, it is more of psychotic symptoms, and the course of the illness is more suggestive of a non-affective disorder. And at the same time, we've had children who do start with the psychotic episode, but by second or third episode, they become more clearly somebody who has a mood disorder. So both things are well known. Right now, I would say the evidence is more for a mood disorder, especially with the comorbidity of eating disorder and OCD. Not that it can't happen in psychosis. But the incidence of depression in eating disorder itself is about 30% versus psychosis, which is much lesser. And OCD in eating disorder is also much higher, almost about 40-50%. And in Asperger's eating disorder, in our samples, it is also very high. Western samples don't show it as being that high, but we do have a prevalence of autism spectrum difficulties in the soft spectrum, not really all the symptoms. Maybe they would be in the broader phenotype group, is also much higher. So because of those comorbid illnesses also, currently I would be more in favor of depression. But I think this is still a young boy, his brain is still growing, and how it is going to evolve is something we're going to have to wait and watch. Which is why I think discussing prognosis and what next for the child with parents at least is quite important.
Thank you for clearing that one. What a fascinating session it has been. So we'll probably take concluding remarks from Dr. Jayaprakash Rajan and then we'll end the meeting. Sir, please go ahead.
Yes, thank you, Bhumika, for a good presentation and very fascinating discussion by Dr. Satya and Professor Manohari ma'am. Ma'am, actually, I wanted to ask, like, this is a very, very difficult case, and is not the usual thing we see in kind of adult psychiatry. The most enduring part of this is how to engage this family and the adolescent boy for a long-term therapy, whether it is BT now and subsequently some component of CBT. But I remember Paul Russell sir's thing. I did one seminar in my DPM time, and I was thinking that like giving the most difficult food to eat for the first and then gradually augmenting with other food. Then sir said, no, that will be more counterproductive. So better to give something which child likes or adolescent likes, and then gradually add those other kind of food. So this reminds me, like, it will be useful for this child also, like the things he likes to eat, or whether he likes to drink the fruit juice or other things, and then add the other stuff which he's trying to spit out, the pattern which Dr. Bhumika showed us in the video. So definitely it's a challenging case, and the early days in therapy and medications, and most of those segment or domain or aspects are being discussed by both Professor Satya and Honori ma'am. Thanks a lot to all the audience, all the PG students and residents, and our moderator and Dr. Jigyasa also. So thanks a lot, and kindly pay our regards to Ashok sir and the team in at St. John's, and Priya ma'am, Susila ma'am, and all Anju ma'am, all my mentors at CMC.
Sure.
Thanks.
Thanks a lot. Thank you so much. And it was a very good presentation and a very invigorating discussion, I'd say. And thanks, ma'am, for the input, Manohari ma'am. It was, we've had, I think we've done parallel sessions in many places, but at the same platform, it was very exciting to sort of have a discussion, ma'am. Thank you so much.
Thank you. Thank you for being my co-chair. And I enjoyed this meeting, and I'm really amazed to see the participation. So many people who have logged in, which is not at all common on a Monday evening, I would say.
Sure.
Thank you for asking me to be here. It was a thoroughly enjoyable input.
Thank you and all the best. Bye-bye. See you all.
Bye-bye.
Ma'am, bye-bye.
Bye, ma'am.
Thank you, sir. So with your permission, shall we wind up this session?
Yes.
Thank you, sir. So from here now, I'm ending this meeting. Have a great evening to all.